Imagine walking into a clinic to fix an old acne scar, or maybe you're going to physical therapy for a bad knee,
Right.
and the doctor sits you down and tells you that their grand plan is to intentionally set off a microscopic bomb inside your tissue.
It sounds completely like science fiction or, a medical malpractice suit waiting to happen.
Exactly. But that is exactly what's going on in clinics across the world every single day. We are currently blasting our skin, our joints, and even sensitive internal tissues with high-intensity lasers, acoustic shock waves, and radio frequency.
I mean, it completely flips the traditional logic of medicine.
Yeah.
We're so used to the idea of protecting injured tissue.
Yeah, like putting a cast on a broken arm.
Exactly. You put a bandage over a cut. But with this technology, we're using controlled demolition to force a biological response.
Controlled demolition, that is the perfect way to put it. And that's exactly what this deep dive is all about today. We're looking at the booming world of energy-based devices, or EBDs.
It's a massive field right now.
It really is. We've pulled together clinical guidelines from the Journal of Drugs and Dermatology, orthopedic rehab protocols from the journal Medicina, laser tattoo removal mechanics, and a very stark, formal FDA warning.
Yeah, it's a wild mix of medical disciplines. But whether you're treating a faded tattoo or severe osteoarthritis, the underlying physics of how we use energy to manipulate human cells is surprisingly similar.
So for you listening, consider this your ultimate cheat sheet. Before you let anyone point a laser or a shockwave device at you, you really need to understand the physical mechanics of what is happening under the surface.
Right, because it's not just magic.
Exactly. You need to know why the skin preparation you do weeks beforehand is actually the secret to success. And you need to know where the safety boundaries lie when this technology gets pushed to its limits.
Bet you frequently does.
Yeah. So I want to jump straight into the illusion of the Zap and Go treatment. You see these videos online of tattoo removal, and it looks like a magic wand just quietly dissolving ink.
Oh, the visual is incredibly deceiving. There's absolutely nothing quiet or gentle about it. It is, well, it's highly calculated trauma.
Let's break down what's actually happening there, because the mechanics are just fascinating. There's this visual phenomenon that happens the second a laser hits a tattoo, called laser frosting.
Right, the skin turns white.
Yeah, it instantly turns this chalky, bright white color. And for a long time, I just assumed the laser was burning the surface of the skin.
A lot of people think that.
But the energy isn't just burning, it's actually creating an acoustic shock wave.
Think of an opera singer hitting the exact right pitch to shatter a wine glass across the room. The laser is the voice, and the ink pigment is the glass.
Oh, wow.
Yeah, the laser fires at a wavelength that perfectly matches the absorption spectrum of that specific ink color.
And it happens so fast that the ink clusters literally explode inside the skin.
They shatter, and that tiny instantaneous explosion releases microscopic gas bubbles into the intracellular spaces.
Ah, so that's what the white frosting is.
Exactly. That is what causes the skin to look white and chalky. It's a visual confirmation that the acoustic energy has successfully shattered the target.
That's wild.
And within 24 hours, those gas bubbles dissipate. The skin turns red and swollen as the body's immune system rushes in to sweep away the shattered ink particles.
Wait, so the device doesn't even remove the ink itself. It just breaks it into small enough pieces so
Yeah.
your own immune system can carry it away?
Precisely. The ultimate goal of almost all energy-based devices is to trigger a micro-controlled inflammatory cascade.
Mm-hmm.
You're basically tricking the body into thinking it has sustained a specific minor injury.
Which forces it to rush healing factors like collagen and elastin to the area.
You got it.
But that raises a massive red flag for me. If you're pumping thermal or acoustic energy into human tissue to create an inflammatory cascade, what happens when it gets too hot?
That is the big question.
Right, like I was reading about non-ablative fractional laser resurfacing. Doctors use it for things like severe atrophic scarring. If you have deep acne scars, they have to turn the energy up pretty high.
Well, let's clarify what a fractional laser actually does first. Instead of acting like a flashlight that just burns everything the beam touches, a fractional laser acts more like a pixelated image.
Okay, pixelated how?
It punches microscopic columns of heat down into the tissue, but it leaves the healthy skin around those columns completely untouched.
Ah, so there's intact skin left behind.
Right, those untouched areas act as bridges, supplying the cells needed to heal the tiny holes really rapidly.
But even with those bridges, you are still shooting intense thermal energy into the skin.
And that leads to the biggest risk in this entire field, bulk heating.
Bulk heating.
Yeah. If a practitioner is trying to treat a severe atrophic scar and they make too many passes over the same small area of skin, the tissue loses its ability to dissipate the heat.
So the temperature of the entire area just rises non-specifically.
Exactly. Think of it like cooking a steak. You want a quick sear on the outside, but if you leave it on the heat too long, the inside starts cooking too.
Yikes. So what does that do to the skin?
That bulk heating destroys the delicate proteins in the skin. It leads to thermal blistering or, ironically, much worse scarring than the patient originally came in for.
So how do they prevent that? There has to be a physical limit.
There is a very strict clinical safeguard. Practitioners measure the treatment density in microscopic thermal zones, or MTZs.
Okay.
The protocol states that when the density reaches about 500 MTZs per square centimeter, which is roughly 4 passes of the laser, the doctor must physically stop.
They just stop mid-treatment.
Yes. They pause for a full 1 to 2 minutes and actively cool the skin with a machine called a Zimmer cooler. It literally blows freezing air onto the tissue until it is physically cool to the touch.
Wow, so you have to reset the baseline temperature before you can fire the laser again. Well, that brings us to a huge realization about how we prepare for these procedures. If the danger of thermal blistering is that high, you can't just walk into a clinic off the street, lie down, and get zapped.
Oh, absolutely not.
So what short-term topical preconditioning protocols actually reduce the risk of thermal blistering during energy-based therapy for severe atrophy?
This is a major area of focus right now, especially when dealing with severe atrophy where the skin is already compromised and thin. Aesthetic dermatologists have realized that short-term topical preconditioning protocols are absolutely mandatory.
You have to fortify the canvas before you strike the match.
Exactly.
I saw a massive list of pre-care requirements in the dermatology guidelines. They're telling patients to start a strict regimen at least 2 weeks before a procedure.
Yes, 2 weeks is standard.
We're talking broad spectrum, SPF 50+, humectants, and high doses of niacinamide. I mean, I understand the sunscreen, but why on earth do I need niacinamide 2 weeks before a laser hits my face?
It comes down to the architecture of the stratum corneum, which is the outermost layer of your skin. Think of it as a brick-and-mortar wall.
Okay.
The bricks are your skin cells, and the mortar is made of lipids, primarily ceramides. When you apply niacinamide, you are actively stimulating the skin to produce more ceramides and free fatty acids.
So you're thickening the mortar.
Yes, you're physically building a stronger, more hydrated wall to absorb the impact of the heat.
That makes total sense.
A well-hydrated, lipid-rich skin barrier is far more resilient to thermal stress. It dissipates the heat more effectively, which drastically lowers that chance of bulk heating and blistering we talked about.
You're basically creating a sterile, robust healing field.
You have to.
And the post-care is just as intense, right? It depends on how deep the fire burned. Like if a laser is ableve, meaning it actually vaporizes that outer brick and mortar wall entirely, you need thick, heavy emollients.
Because you've literally blown the roof off the house.
Yeah.
The skin is completely exposed to bacteria and massive water loss.
So you slather on these ceramide-dominant barrier creams to act as a fake roof while the skin re-epithelializes or, grows a new top layer.
Right, and some of the clinical roundtables highlight specific formulated lines, like Elastin Skincare's regenerating skin nectar.
Oh, to calm down that micro-inflammatory cascade.
Exactly, because if you let the inflammation run wild, you get permanent textural damage.
Which brings up a very practical question.
Let me guess.
Does it hurt?
I mean, we are talking about microscopic thermal zones, shattered ink, and blown-off skin barriers. So yes, it hurts. Pain is a known and planned-for variable in these procedures.
But nobody wants to just bite a towel and suffer.
And they shouldn't have to. The clinical data strongly advocates for active, non-invasive anesthesia.
Like numbing cream.
Yes, but intense numbing cream. There's a specific trial that illustrates the sheer necessity of this. They tested a highly concentrated peel cream formulation, 7% lidocaine and 7% tetracaine.
That is way stronger than anything you get over the counter.
Much stronger. The protocol requires the patient to sit with this cream on their face for a full 45 minutes before a fractional laser procedure.
Wait, 45 minutes? That seems like a really long time to just sit in a waiting room with cream on your face.
It does, but it takes time for those chemical agents to penetrate the stratum corneum and actually reach the nerve endings in the deeper dermal layers.
Ah, okay.
But the wait is completely worth it. On a 10-centimeter visual scale for pain, the patients who had no active anesthesia reported a mean pain score of 8.6 out of 10.
8.6 is severe gripping pain.
It is borderline intolerable. But the group that used the 45-minute lidocaine tetracaine protocol dropped to a mean score of 3.0.
Wow. From an 8.6 to a 3.0, that takes a traumatic experience and makes it completely manageable.
Exactly. And it ensures the patient doesn't flinch, the doctor can perform the procedure safely, and, the patient will actually return for their follow-up sessions.
Right. Okay, so we've established that the medical field has developed incredibly specific, rigid protocols to protect the face and the neck.
Yes, very rigid.
We understand the physics of the burn and the chemistry of the barrier, but the industry hasn't stopped at the skin. We are seeing a massive expansion of these EVDs into highly sensitive internal mucosal tissues.
Yeah, we really need to talk about the booming market for vaginal rejuvenation.
This is a space where commercial marketing, clinical innovation, and intense regulatory oversight are just colliding head-on.
It's highly controversial right now.
Let's lay out what the manufacturers are actually claiming. There are devices heavily advertised right now. Brand names like Vitone, Forma-V, Morpheus 8V, and various fractional CO2 lasers.
Right.
The companies market them as treatments for severe vaginal atrophy, the genitourinary syndrome of menopause, and pain with intercourse, which, these are very real, very painful conditions.
Absolutely. And the mechanism of action they propose sounds very similar to what we just discussed with facial skin.
The microdamage.
Yeah. The manufacturers claim that by applying radiofrequency or laser energy internally, they can create that same microinflammatory cascade. The idea is to stimulate collagen and elastin formation, increase local blood flow, and promote healthier tissue growth in the vaginal wall.
And some of the devices use a different kind of energy, too. Like Vitone, for example, uses electromagnetic muscle stimulation.
Right.
The claim is that a single 30-minute session forces the pelvic floor to contract thousands of times. It's basically doing 17,000 Kegel exercises for you.
Which, on the surface, sounds like a miraculous breakthrough.
It really does. But we have to look at the reality check that came straight from the FDA.
We do. On July 30, 2018, the FDA issued a major formal warning regarding the use of energy-based devices for these specific vaginal conditions.
And their position was not vague.
Not at all. The FDA's position is unequivocal zero clearance. They explicitly stated that no vaginal laser or radiofrequency device is cleared or approved by them for the treatment of these symptoms.
They didn't just say they needed more data. They issued warnings about severe documented risks.
Yeah, the FDA highlighted reports of serious adverse events, specifically severe vaginal burns, scarring, and lingering pain.
The language from the FDA commissioner at the time, Dr. Scott Gottlieb, was incredibly sharp. He explicitly called the marketing of these devices for these purposes deceptive and egregious.
That's a strong word for the FDA.
Very strong. And the detail that really stood out in the sources was his concern about the target demographic. He called out the fact that these unproven procedures were being aggressively marketed to women experiencing early menopause as a direct result of breast cancer treatments.
And we have to look at the biology of why the FDA is drawing such a hard line here.
Right, because tissue is tissue, isn't it?
Well, no. You can't just assume that because a fractional laser created a beneficial response on the face, it'll do the same thing internally.
Oh, because of the barrier we talked about earlier.
Exactly. The skin on your face is highly keratinized. It has that thick, tough stratum corneum, the brick and mortar. Vaginal tissue is a delicate mucosal lining. It doesn't have the same architectural armor.
Ah. So a laser setting that triggers healthy collagen on your cheek might cause a severe scarring burn internally.
Exactly the FDA's concern. The evidence to justify that risk simply isn't there yet in adequate scientific studies.
And to you, the listener, we are not endorsing the manufacturers here, nor are we saying this technology will never be proven to work. We're just reporting what the sources say.
Right, we're remaining totally neutral.
But you have to be acutely aware of this massive regulatory gap. There is a huge difference between a glossy brochure in a waiting room and what the FDA considers proven and safe.
Absolutely.
When you understand that these devices fundamentally operate by causing calculated tissue damage, you naturally have to ask much tougher questions about the safety of the tissue being damaged.
It is the ultimate lesson in understanding the mechanism before accepting the treatment.
Let's take that concept and shift gears entirely. We've talked about the surface of the skin and internal mucosal linings. Let's go deep into the body.
Okay, let's do it.
Let's look at bone, joints, and deep connective tissue. Specifically, how physical energy-based therapies are used in the management of osteoarthritis.
The rules of the game change completely here.
How so?
Well, in dermatology, the goal is altering the physical structure of the tissue for aesthetic or functional remodeling, right? But in
Mhm.
physical rehabilitation for something like a severely arthritic knee, the goal is restoring mobility.
And reading through the orthopedic sources from Medicina, I was hit with a massive surprise. The central theme across all these clinical studies is that these lasers, shockwaves, and electromagnetic fields are not designed to cure the osteoarthritis.
They do not reverse bone degradation, they do not grow back lost cartilage, and they absolutely do not replace physical exercise.
Then what are they doing?
In physical rehab, energy-based devices are classified strictly as enabling tools. The literature refers to them as pain bridges.
Pain bridges. I love that concept. A bridge to get you where you actually need to go.
Exactly. Think about a patient with severe osteoarthritis in their knee. Every clinical guideline universally states that progressive exercise, strength training, and walking are the core gold standard treatments.
Right. Movement is medicine.
But if a patient is in so much agony that they physically cannot bear weight, or their nervous system is causing the surrounding muscles to spasm and guard the joint, you can't just tell them to go do squats.
No, they'd look at you like you're crazy. You need a bridge to get them to the squat rack.
Yeah, is where a device like TICAR comes in. It stands for Transfer Energy Capacitive and Resistive Therapy. It delivers a specific frequency of radio waves into the deep tissue.
But how does a radio wave help an arthritic knee?
It creates controlled endogenous heating.
Wait, endogenous, meaning the heat comes from the inside out. How does that not just cook the muscle?
It's a brilliant piece of physics. The device itself isn't hot. Instead, it sends electromagnetic waves into the tissue that cause the water molecules and ions inside your cells to vibrate rapidly.
Oh, wow.
And that microscopic vibration creates friction. And that friction generates heat deep within the joint capsule itself.
That is wild. Your own cells are generating the heat.
A physical therapist might use TICAR for 10 to 20 minutes immediately before a therapy session. That deep internal heat drastically increases local blood flow, melts away the joint stiffness, and relaxes the neurological muscle guarding.
It unlocks the joint just enough so the patient can actually tolerate the exercises that will provide the real long-term benefit.
Exactly. It's the bridge.
The variety of energies they use to build these bridges is incredible, too. Besides the internal heat of TACAR, the sources detail ESWT extracorporeal shockwave therapy.
Yeah, that's a fascinating one.
It delivers intense acoustic pressure waves deep into the joint over a series of weekly sessions. But it's not breaking up ink like the tattoo laser, right? It actually modulates nociceptor sensitivity.
Right. A nociceptor is simply a sensory nerve ending that screams pain to your brain. By hitting those nerve endings with repeated acoustic shock waves, you overwhelm them. You deplete their neurotransmitters, effectively resetting the pain signal and deadening the sensitivity in that specific area.
So it just turns the alarm off.
Essentially, yes.
Then there is photobiomodulation, or PBMT, which uses red or near-infrared light. What fascinated me here was the dosing.
The dosing is very specific.
Yeah, the literature shows it only works within an incredibly strict window, usually around 4 to 8 joules per point at very specific wavelengths. If you underdose it, literally nothing happens.
Because PBMT is not a thermal therapy. It doesn't use heat. It relies on non-thermal photochemical effects.
Okay, what does that mean?
The light particles, the photons, have to penetrate the tissue and be absorbed by specific enzymes inside your cell's mitochondria. It's a biological lock and key mechanism.
Oh, so if it's the wrong light, the key doesn't fit.
Exactly. If the light isn't the exact right wavelength and intensity, the key doesn't turn, and the mitochondria don't increase their cellular energy production.
They even use mechanical energy as an enabler. The sources outline lower body positive pressure treadmills, or LBPP.
Those are amazing.
It's an inflatable chamber that seals around your waist and literally lifts you up, unloading 50% to 80% of your body weight so you can walk without your joints grinding together.
But whether it is a high-tech anti-gravity treadmill or a deep heating radio wave, there is a golden rule that dictates how these devices are used in a clinical setting.
Right.
The sources are absolutely adamant about the clinical stop rule.
What does that mean for the patient?
It means accountability. If a physical therapist applies an energy modality and it does not produce a measurable improvement in the patient's ability to participate in active physical therapy after a short trial period, it must be discontinued.
So you don't just keep zapping a painful knee for 6 months hoping it magically gets better on its own?
Never. These devices are not allowed to become a crutch for passive care. If the pain bridge doesn't actually help you cross over into active movement and exercise, it is failing its clinical purpose.
If we synthesize this entire journey we've been on, energy-based devices really are marvels of modern science.
They really are.
We are using acoustic waves to bubble away tattoo ink. We are using fractional lasers to pixelate the skin and rebuild acne scars. We're using endogenous radio frequency to heat an arthritic knee from the inside out just so a patient can walk again.
It's incredible.
But the grand illusion is that these machines are standalone magic wands.
They're completely dependent on the environment we create for them.
Yes. Their true power relies on the context. It's the weeks of topical preconditioning with ceramides and niacinamide to fortify the skin barrier. It's the meticulous post-care with thick emollients and cooling.
Right.
And in the physical rehab world, it's the active, sweat-inducing exercise that absolutely must follow the energy treatment.
It requires the patient to be an active participant, carefully managing the controlled demolition. But as we map out the exact frequencies of light, sound, and heat that trigger human cellular repair, it opens up a fascinating question about where all of this is heading.
Where do you see it going?
Well, if we can use targeted physical energy to force the body to regenerate its own tissue, to rebuild its own collagen, to reset its own pain receptors, to heat its own joints, at what point do we stop relying on chemical pharmaceuticals?
Oh, wow.
We have spent the last century taking pills to alter our biology chemically. But if we perfect this technology, are we looking at a future where your medicine cabinet is entirely replaced by a battery pack?
Replacing the pharmacy with a battery pack. That is an incredible thought. It really is a controlled fire. You just need to make sure you have the water hoses and the fertilizer ready before you strike the match.
Well said.
To you listening, thank you for joining us on this deep dive. And remember, before you step under the laser, check the science, understand the physics of the burn, and ask your doctor exactly what the post-care plan is. We will catch you next time.